Pleasure being with you guys today. I really appreciate the association there in Kentucky giving me an opportunity to present and a little bit about me. I am currently the president of a company that I started earlier this year. It's Dominion Prosthetic and Orthotic Purchasing Group. And we are a group purchasing organization. We're a GPO specifically focused on small to mid-size O&P practices and to help them basically save money on their O&P spend. So we're really excited about that, and that's getting off to a really good start. So maybe I'll have an opportunity to talk with some of you folks about that at some point after the presentation today. Before that, I spent a few years with an O&P practice here in the eastern part of Virginia. I was the chief operating officer for those folks for 3 years. And then before that, for about 24 years, I worked in the nonprofit health system world, both in South Carolina, but primarily in Virginia. I'm a native South Carolinian. And with the health system roles that I had were primarily over on the home health care side. So home health and hospice and home medical equipment, O&P included there, private duty, home infusion pharmacies. So those areas. So anyway, it's great being with you. And I hope you'll find today's presentation interesting. It's a slightly different subject matter, I think, than what is typically covered at O&P conferences, but it's one that I feel is much often thought about and discussed within the O&P practices. So I hope you're going to find the information helpful and insightful. Though the tools that I'll present may be more directed towards the ownership level or those within the practice who are involved with staffing, I really believe that all team members can benefit from having an understanding of this particular approach as a guide to achieving optimal staffing. Obviously, for an organization to be successful, whether it's from a financial standpoint, quality of care, patient satisfaction, and employee satisfaction, the organization has to be appropriately staffed. The question is always, what's that right number of staff? And typically, depending on who you ask or when you ask it, you're probably going to get different answers. So figuring out that staffing dilemma kind of requires a little bit of an arts and science approach. Unfortunately, for a lot of companies, and not just O&P companies, but a lot of companies, it's usually more based on gut and where the owner feels or perceives the right number of staff are. But I believe that if you take the time to break down a job into somewhat quantifiable components and then establish realistic expectations about the time required for each of those components, you can really come up with a fairly reliable tool to help not only guide your staffing decisions, but it's also going to help you do things like assessing employee productivity. So your staff's productivity or your own productivity. It can help establish incentive programs for staff. It can assist with performance evaluations, and it can really help set clear expectations right out of the gate for your new hires. So a lot of different types of positions in the O&P, typical O&P practice. For today's discussion, where I'd like to take us is really looking at the typical patient care position within the O&P business. So what we're really talking about today is the prosthetist, the orthotist, the fitter, those levels of positions. But this can obviously be applied to most all positions within the practice. Um, First off, without a doubt, paid hours, work hours, productive hours, these are all related but fairly different concepts, and they're going to differ from one organization to the next. But again, quantifying each of these is really a key first step in this process of determining a realistic expectation of the amount of measurable work, basically, that an employee should be able to accomplish. So what we're looking at here is really the full-time employee, the FTE, the 1.0 FTE, is basically going to be paid 2,080 hours a year, which is 260 8-hour workdays, 52 weeks a year, 40 hours a week, 2,080 hours. From paid time, then you start looking at, you've got vacation time, you've got sick time, holiday, education, meetings, and all of that. And what you have to do is you've got to deduct those in order to calculate the hours that are available for work so that you can begin kind of breaking it down and looking at the amount of output that you're going to get. But you have to be able to take those non-productive type hours or non-work hours out of there. So productivity, we always want to base that on work time and not paid time. So for our example today, and I think this is pretty typical for most businesses, here are how I looked at the typical non-work pay categories. So for our example, we're saying that's 80 hours of holiday time per year, 80 hours of vacation time per year. Again, on average, 40 hours of sick time, 24 hours for education, things just like a conference like this, 40 hours of staff meetings and events, again, like this. So for our example, I've identified that there are 264 non-work hours for the typical full-time employee that I have. And so the hours that I have available for my full-time clinician is 1,816 hours. So as we talked about, what we're really focused on today is staffing and productivity for that patient care position within the O&P practice. So what we want to do is we really want to ask ourselves, what is that key driver of a clinician's typical workday? If you can boil the work down for a position to a key driver, it really helps in establishing some productivity expectations, which can help you establish your staffing guidelines. So in my mind, the time spent delivering patient care, which is the patient visit, is really that primary driver for the typical clinician. Now, as you're going to see, patient visit is more than face-to-face time with a patient. So when we talk about patient visit as it relates to productivity and staffing, we're looking at the face-to-face time. Obviously, we're looking at documentation time, parts ordering time, fabrication or interfacing with the fabrication department. There could be some travel time involved, et cetera. So some other reasons that I feel like that it makes sense to use visits and looking at this particular model for clinicians. Again, it's the primary activity driver for the clinical team. Visits typically can be pretty easily tracked. They can be categorized, and we're going to look at that. A lot of scheduling systems out there really provide some pretty good reporting on visit related activity. And not only that, but the clinician's time that's driven by the visit is going to be a driver as well, either directly or indirectly, for your admin team, your support team, and any kind of in-house fabrication activity. I have been in on the conversations before about, is revenue per employee a good measure of productivity? I think revenue per employee is really a good benchmark to look at. And AOPA does an annual survey, an annual financial survey. They look at revenue per employee. I think it is a really good benchmark, but I don't think it is a good measure for productivity or necessarily staffing. It can be a real general guideline, but at best. So reasons why, not all work activity generates revenue. There are obviously big variances in the O&P world in product revenue. You can have a patient receiving shoes. You can have a patient receiving a brace. You can have a patient receiving a prosthetic leg. And a lot of times the time required may vary some, but not greatly, but the revenue involved there can be huge variances in that. So, and revenue is inconsistent. Some places look at it at net, which they expect to get paid. Some places measure revenue based on gross billing, some on cash, et cetera. So for those reasons, I just really feel like that when we're looking at patient care positions, visits are the best productivity measure. So obviously there are different types of visits, and depending on the type of visit that's being provided, there's going to be different amounts of time, energy, input, et cetera, required by the clinician to provide that optimal patient care. So for the purposes of our model, we're going to define our visit as one of 4 visit types. So we've broken our visit down into whether it's a consult, it's an eval, it's a delivery, or it's a follow-up visit. Again, there are other possibilities. There's additional subcategories. You can break these down further, but these are really, I think, the primary visit types that capture the majority of that patient face-to-face activity. Important note, when we're tracking visit data for staffing and productivity purposes, and this is probably obvious, but some folks kind of get wrapped around a schedule. We want to look at actual visits made. We don't want to really focus much on scheduled visits. Scheduled visits, as we know, can be canceled, rescheduled, patients don't show, et cetera. So we really want to make sure, and particularly as we're looking back at some of that historical data, we want to make sure that we're looking at actual visits and not scheduled visits. All right, so for our example, we're going to start out, and with this, you're going to make some assumptions. Your assumptions can be based on what you think, input from the team, and I think that's very important. We'll talk about that in a little bit, but really getting input from all of your team as you go through this process about some of these expectations, or maybe you go back and you look at some historical data. That's always helpful. But this is kind of how you started out. So we're going to assume that on average, here's the breakout for our typical clinician in our practice in terms of their visit type mix. So for our example, we're assuming that the typical full-time clinician, 10% of their visits will be consults, 30% evals, 30% of their visits will be delivery, 30% will be follow-up visits. All right, so now we want to start looking at what constitutes that visit. What are the components? And remember, I said earlier, face-to-face time with the patient is only one component of a visit as it relates to calculating productivity and looking at staffing guidelines. So in our example, what we are saying is that on average, we expect a consult visit to require 20 minutes of face-to-face time with the patient. Eval on average is going to take 45. The delivery visits on average going to be 30 minutes and 20 minutes for a follow-up. I'll keep stressing that the amounts of time that we're looking at and allotting to the various components here are averages, which are hopefully based on some good historical data from your own practice. That's the best source. But if you don't have historical data, you may want to think about doing something like a mini time study project to come up with realistic averages. That's always helpful, and you can do something like that within a short time frame and get some good data there. And if really neither of these are much of an option or a viable option for you, at the very least, just use reasonable assumptions and expectations for what you think that it should be. And again, I'll mention this several times. It's really important to include your team members in this process from the very beginning. Team member feedback is it's going to result in better data. It's going to make the tool a lot more effective, and it's really, as important as those are, and probably more importantly, it's going to increase the likelihood that your team is going to be on board and bought into the overall plan, because folks start getting a little bit nervous when you start talking about looking at productivity and you start talking about looking at times required and times expected. That's completely understandable. When you can really bring them in and let them know that this is something that you're putting together that's going to benefit everybody in the organization and they're involved from the beginning, that's a big help. Okay, so continuing on, looking at components of the visit. We mentioned documentation time. In our example, we are saying that on average, these are the typical amounts of time associated with documentation. And again, just for the purposes of this example, and these would be averages, and these would be averages that would typically, you would think, would play out over time. Travel time. So depending on your particular practice, you may or may not have travel time. Some practices have very little, some may have quite a bit. If the majority of your patients come to your office, but occasionally your clinicians go to the home or to a facility, what you're going to want to do is you're going to want to build in at least a small amount of travel time when you're calculating your productivity. Don't just leave it out, because even in those instances where it doesn't occur much, when it does occur, it could be, it could involve an hour or more on any given day of travel time. So here's what we've plugged in terms of our example. Obviously, this is going to vary a lot for each O&P practice, but you just want to identify, you don't want to leave this out if it does happen, even if it doesn't happen, but on maybe more rare occasions. But build in that travel time if you sometimes have it, and build in more if it happens quite a bit. Obviously, the clinicians are, in most practices, are going to be involved in parts ordering and fabrication time, whether that's doing some hands-on fabrication or interfacing with maybe it's an in-house lab, maybe it's a central fab location, but the clinician is going to be involved in that process, and you're going to want to build in some time for that, and these are the times that we have built in for our example for that. So what we've done, those are the components that we have come up with for our typical visit type. So we've got 4 visit types, and we've determined as primary components each and the average amount of time for each. So you just do the math across, and you have the total amount that we expect it to take a clinician on average to complete the visit. So again, we know without question it's rarely, if ever, it's going to hit exactly on these times. We're not trying to pin that down exactly and hold our clinicians to it. We're just looking for reasonable targets for each of these work activity drivers. And we can now use those as reasonable assumptions to establish productivity expectations that are in turn going to help us determine our staffing needs. Okay, so there's our total visit times for each of the visit types that we have identified. So what we want to look at now is that on those days that our clinician is working, so the days at work, what is the expected productivity, and assuming that it's typically going to be an 8-hour workday. So you want to build in some time that is going to be non-productive time per day. Maybe that's morning huddles, maybe it's trips to the break room or the bathroom. Maybe it's just, some downtime, some chit chat time. There's going to be downtime during the day. We know that. Build it in. What we did for our example, we used 30 minutes. So we're saying out of an 8-hour work day, and obviously you've got lunch and things like that already factored out of this. So this is the 8 hours that you expect that folks are going to be available for work. They're going to be productive. Our expectation is 7.5 hours a day. Okay, that's going to be different for every practice. Okay, so next step, what we want to do is we want to use this information. And now we want to come up with a number of visits that we can typically expect from our full-time clinician per workday. So in this table, what we're showing each of our visit types and the total time that we calculated each will take. That middle column that's titled total per day, what that is, that's simply showing the number of that particular visit type a clinician should complete if that was the only type of visit that he or she were performing. So it is just simply 7.5 hours or 450 minutes of the day divided by the number of minutes assigned to each visit type. So for example, the first row there, if a clinician were only doing consult visits, then he or she would be expected to do 12.85 per day and so on. What we talked about earlier is that we obviously know our clinicians are going to perform a mix of those visit types, and we assigned that percentage that represents the proportion or weight of each type that we would typically see over time. It's going to be different any given day, but over time and based on our expectation, this is kind of that mix that we're going to expect to see. So all we're doing now is we're just multiplying the number of visits per day by the weight or the expected percentage that we're going to see those types of visits made. And now that gives us a weighted average of the number of visits that should be expected to be completed within the typical 8-hour workday. So in our example, we've landed on 8.96 or right at 9 visits per day. So we can take it a little further. We feel good about that number. We've had good input from folks. We feel like we've got good expectations, good assumptions. We've captured the majority of the productive time and non-productive and paid, non-paid time and all of that. We got a good number. Now we just simply calculate the number of visits per year expected from that full-time clinician. And if you remember back one of the first slides, we determined for our practice expects each full-time clinician to work 235 days per year. We were paying them for 260 days. They had all of that non-work paid time, vacation and holiday, et cetera. So 8.96 visits a day, 235 work days. Now we've got an expected work output, 2,105 expected visits on average per clinician. So really what you can do here, you can take it a step further, and I think this is helpful at times, particularly if practices are looking at adding locations. Things are changing a little bit, and maybe you want to think about staffing, or you want to think about productivity, maybe in terms of well, how many patients can we handle? At what point in terms of our patient volume should we be thinking about adding staff? I'm thinking about opening a new location. Do I really need to add another staff member? Do I have enough capacity maybe within the current staff to hold off on adding that position for a little bit? So really, you can kind of do this and kind of convert this into the number of patients that you would expect your full-time clinicians to see over the course of a year. It's pretty straightforward math. So for our example, like I said, I'm assuming that each patient's going to receive an eval, a delivery, and a follow-up. I'm really assuming that all of my patients are going to receive those 3 visits, and I'm assuming that 1 in 10 patients are going to get a consult. Nothing magical about any of this, only that these are the expectations built into our example. And I know that not every patient's going to get a consult, but some patients will get a consult. So I'm just building something in to recognize that. So doing the math, what I'm saying here with these expectations is that each patient on average is going to get 3.1 visits. So again, if you just do the math simple, dividing the number of visits that I expect my full-time clinician to make by the number of visits I expect each patient to receive, I've got a target of 679 patients per clinician. There's nothing magical about this. This is not etched in stone whatsoever, and you can see that all along the way we have built these numbers around assumptions and averages and expectations. But it's gotten us a number. It's gotten us something that we can kind of put our hands around a little bit, which I think is very helpful. All right, so recapping, what do we do? So how did we start? First thing we did is we kind of pulled the time piece apart. We looked at it. We looked at paid time. We looked at work time, and we looked at productive time. So we recognized the components of the time, and we're building assumptions around each so that we can come up with some hopefully pretty reliable productivity and staffing guidelines. You want to look at that measurable process that correlates with work activity, or that productivity indicator. For us, for the typical patient care position, we feel like visits are a good example. Other positions within your practice, you will want to look at probably some other type of productivity indicator or work activity as a guide to helping you establish some expectations on productivity and on your staffing levels and where those need to be. From there, with the work activity of visits that we chose, we looked at the primary components of that activity. So we looked at visit types, and then we looked at the typical required steps or the components of each visit. Hopefully we made reasonable assumptions about time required for the steps along the way and the probability of what was going to occur and how much and how often we expected these different components to sort of play out over time. Again, this is always looking over time. From there, we calculated an expected productivity. We had 8.96 visits per day. You know, we came up with a number that we think should be a pretty good guide, pretty good ballpark. What we want to do from there is we don't want to just let this lay dormant. We want to now take what we have done, and we want to feel good enough about it that we're going to use it on a regular basis going forward in our practice. We're going to compare ourselves, our actual performance going forward, to what we expect, you know, to this benchmark, and we're going to continue to make changes to this target as we learn more over time. Because now that we're really looking at it, we're tracking it, we're paying more attention to it. We're building in maybe some different assumptions and expectations than we did initially because we weren't thinking about things. But if you just go through the process, you just throw it all out on the table and you put a number out there, you say, okay, there's our number, and you just kind of leave it at that, and you don't build it into a living, breathing part of your organization, it's not going to be as useful. So let's always work with this number, and let's always compare ourselves, and let's always set the bar a little bit higher so we can get, so that we continue improving with this. You're going to focus on those unfavorable variances. And you're going to want to look at those objectively. So when you've got this productivity measure in hand, and now you're starting to compare, and now you're seeing that certain individuals within the organization are falling short of that expectation, you're not just going to assume that they're just not getting it done for you. You're really going to want to look at that objectively, open-minded, thoroughly, because there very well could be a lot of process stuff put in place that is not built into the productivity measure for that particular clinician or position. There, sometimes things just small businesses, folks wear a lot of different hats, and so you want to look at that objectively. But at the same time, you want to make sure that if that's the number, and that's the number that particular folks should be hitting, then you really want to help them get there if they're not there, and you're going to work together to do that. And that's the very last step. Is you're going to involve your team in all of these steps from the very beginning. Folks like to be involved. They don't like to be called into a meeting to say, hey, we've established productivity standards and here they are. That's probably not going to go over very well. And having done this before, going into it expecting to have a lot of pushback and a lot of challenges to it. I found that when you involve the staff, you listen to them, and you build that into your model, what they're telling you and how things go and how the processes are, and this is why it takes this much time. It just becomes a more effective tool. People are bought into it, and in my experience has been that staff really they like knowing what the expectation is, and if it's measurable. Most folks they like knowing what it is, and they like knowing how they're doing, whether they're there or not, if they feel like it's realistic. Okay, there you go. I appreciate your time on that. I hope there's questions. I'd look forward to hearing those and having some dialogue. And I know Elizabeth said she's going to share my contact information with you as well afterwards. And for folks who will be looking at this that's not live, I'd love to connect with you via email or phone and walk through or talk through some of this. So thanks. I appreciate your time.